Got it. Thank you so much, Martin. Very nice. Thank you for the introduction. And yeah, pleasure to be here. Honored to be here with a very interesting group. And I'll take you through, yeah, like Martin said, a bit of the context, a bit of our analysis of the situation, and very happy to receive any questions. So I'm someone that I would like to show you a few pictures and a few slides. So I made a presentation, which I will share with you. Let me see. Sure. Martin, you can you see?
Yes.
Perfect, perfect. Well, so my name is Djoen Besselink, and as Martin said, I'm the country representative. So I am responsible for all activities of Doctors Without Borders inside Somalia. Currently, I'm in Nairobi, where we also have an office, but normally I go to the project inside Somalia. So just as a little side note on the coming 15 minutes, if you have any specific questions or clarifications, I have no problem by just, if you unmute yourself and intervene, or indeed raise your hand. And I also know that there's a chat. So if there's any questions coming up, feel free to follow one of these steps in the coming 15 minutes. So today I'll take you through the most recent changes in the context. Unfortunately, every other week the context is different in Somalia, but I'll take you through my understanding of the last few months, and then highlight the impact it had on and has on malnutrition and the health situation. And I would like to start by indeed looking at these four triangles, where for me the context is really a combination of the different layers that we see in Somalia. So at the foundation of everything, it's a country that for decades has a horrible access to healthcare. It's one of the countries with the worst female mortality rates, maternal mortality rates. Safe delivery is a huge question. There's not enough staff, not enough equipment, very little hospitals available for non-private access. So access to healthcare is a big question all over the country. On top of that, it's a country that has seen conflict for the last 20, 30 years. In every country, every conflict, I would say the layers are communal conflict. We see conflict between groups, between families, between individuals, but also between states, between international actors. The Americans are here. There's non-state armed groups, there's the Shabab. So conflict is pretty much the day-to-day business. It's all around, every day, full in your face. On top of that, the malnutrition, it's something that has been in Somalia also for decades. It's not a thing of the recent drought. It's something really every year, different seasons. It's a country with 2 rivers only, a huge extreme access, lack of water. So pastoralist communities where malnutrition is a yearly event. And on top of that, we see outbreaks of everything. And of these 4 layers, I'll take you through all of them, because in the end, all 4 together is a bit the context that we see on a daily basis. So today I want to highlight these layers and the complexity of the crisis, that we have a bit of an idea on how complicated it is to work in Somalia, and also to highlight a bit the needs that came up based on these four aspects, but also more recently in the drought that really started in October last year. So the current context, we have a new, the president is not supposed to be there, but as I said, there's ongoing conflict with, since May and June, very big escalation in different areas of the country, where different clans together with the government are fighting the non-state armed group, the Al-Shabaab. Very heavy fights, very heavy front lines with hundreds of casualties each week, what we hear. So very much an ongoing conflict. Somalia is also a country where pretty much everybody owns a weapon, and communal clan conflict is something that is not out of the ordinary to happen on a weekly basis. Then the drought. So since October 2021, I said last year, but time flies, so it's already the year before. It was the first failed rainy season, and by now we have 5 failed rainy seasons in a row. So it's the worst drought that the region sees in about 40 years, and the drought is quite factual. It's really the lack of water, the lack of rainfall, the water level. So severe drought hit the whole region. And if you look at the region, you see Kenya, Ethiopia, Djibouti, they all share the Somali communities. So Somali communities as even a big community in Sweden, but they really cross borders left and right. Somali communities is what we focus on today, is really what we look at. Then access, of course, linked to also the ongoing conflict, but also to the heavy circumstances on the road. Not only access for us, Doctors Without Borders going, but also access for people reaching a safe haven of a hospital. We hear stories of patients walking more than 3 days with no food just to make sure they get to a place where they can find water, food, and shelter. And indeed, politics. So it's a place with a new president since May. A lot of political tension, a lot of political violence, and adds to all the topics of above. So if we look at this drought, the factual thing I mentioned from the drought, we really talk about key indicators that you can measure. An impact of a drought is always a bit more complicated to measure. What is the direct impact of a drought on a food security situation, or what is the direct impact on someone's next meal? But what is very clear is that the market prices, for example, are higher than in the last seven years. So this is food on the market for both cattle, but also for patients, for people. One of the reasons is speculated to be also Ukraine. One of the biggest corn and wheat staple in Somalia comes from that region. So food prices have been massively increasing over the last 2 years, let's say. The climate, so as I mentioned, extreme little rain has fallen in the last 5 rainy seasons. We, for example, in one of the projects, we tried to dig a borehole. We were literally looking for water, and 6 different locations. The bottom was completely dry, up to 80 meters in depth, so extremely challenging to find water. And if you find it, is it clean enough to drink, or indeed, as what it unfortunately did, cholera in several areas. And lastly is indeed the insecurity and the population displacement. Sorry. So the population in Somalia is based on displacement. They are a pastoralist community that travel with their cattle. Most winter, summer, they go follow the water. So it's normal that if you travel through Somalia, you see villages that are abandoned because these are their summer villages. And then you know that months later, they will come back to these villages. So displacement in itself is not so much surprising. But since last year, January, it is in more numbers, bigger numbers, and people transfer and make longer distances than ever before. So we see a huge change in trend when it comes to displacement. So all these factual things they have an extreme impact on the society. So if we look at Somalia, if we look at the priority areas, and the priority areas are not designed by Doctors Without Borders only. This is all the different humanitarian communities, the UN agencies, the INGO. Everybody looks at different areas. Access is one question, the availability of other organizations, the impact of the rainfall, the food prices. So as you can see, is that almost 70% of the country is in priority 1. And if you look at priority 1 and 2, it's almost 90% of the country. There's only a few places where they look at priority 3, and those are places where there's mostly desert and very few people living. So as you can see, it's an extremely high area with priorities all over. For Doctors Without Borders, and you may have heard it in the media, there's a lot of discussion about the drought and the malnutrition and the food insecurity. But for us, we really try to describe the situation as a health crisis. For us, during a malnutrition crisis, as we call it, most people will actually succumb and die from diseases, not necessarily from food insecurity alone. And over the last year, what we've seen is outbreaks of cholera due to the lack of water, water shortage, mass displacement, food insecurity, measles, and thereby the malnutrition. And for us, all these aspects keep it extremely in place. Children that are malnourished are more susceptible to other diseases. Children that have measles have more likely for malnutrition. And COVID also, the immunization level of the country is extremely low. So we see a huge percentage of children that are not vaccinated, and thereby we see child diseases that you would hope never to see again. Polio, again, measles, and unfortunately, we see even a lot of children up to the age of 17 that have measles, which is also something that you would definitely don't want to see. So malnutrition in itself. So if we look over the last 4 years, as I said, it's a country where there's every year a lot of admissions when it comes to malnutrition. So we run periods every year between October and December. We run malnutrition interventions where you see also a peak here. And then again, around June is what we call the lean seasons. So we really run projects there. But what you see is that since indeed 2022 and the drought starting in October 2021, the sum, so the severe acute malnutrition trend has going quite up. And for us in our clinics, we admit around 100 children a week since April 2022. Half of these, so it's around 45% on average, is severely acute malnutrition. The rest has a moderate acute malnutrition rate. We see an extremely low vaccination rate, and indeed we see children caught in all those aspects we meant before. So we see children that are faced with cholera, measles, and malnourished, and we hear horrible stories where people actually have 6 children, of which 1 is extremely malnourished, but they don't have the capacity to bring this child to the clinic because then they can't take care of the others. We hear stories where people eat the leaves off the trees in villages because there's literally nothing else to eat. We hear people walking 3 days, lost people on the way, lost children on the way. And for us, hunger, I mean, it's always a bit of a difficult concept to grasp, but we hear people that haven't eaten for 3 days and have no idea where their next meal is coming from. So for us, it's an extremely challenging situation. So if you look at the whole, state building, war situation, stabilization mission, humanitarian, at this moment, we are really at the phase of acute humanitarian crisis. As we see is that people are extremely in need for basic needs because they don't even have the prospect to look further. So when we ask our patients, what is the main need that you have at the moment, it's extremely basic. It's just food, water, clothes even, and of course, healthcare. But even healthcare is not, food comes first. So at this moment, we're really at the moment of saving lives and looking forward to then possible recovery and hopefully later on something else. But at this moment, it's extremely basic. And if you ask people, what are your solutions? What do you look for? 28% is hoping that an NGO will come and provide basic healthcare. 25% is depending on Allah. But the biggest is 40% has actually no plan. So we did a big survey amongst all our patients, and this was the mainly thing that come up. So it's an extremely desperate situation for the patients that we have. So MSF in Somalia. So we've been in Somalia almost 47 years. So we were in December last year, we existed 50 years, and Somalia was one of the first countries where we started operations. So we are quite big. We're working in these different locations. So we have 4 main projects focusing on maternal and child health. So really trying to reduce the maternal mortality, ANC, so that's antenatal care, postnatal care, pediatric care, neonatal care, really focusing on these vulnerable groups within this conflict. And the other projects are really an emergency focus. So what we see often is that the capacity to increase, the capacity to respond to emergencies by indeed ministries of health, other organizations. We as Doctors Without Borders are, because we are independent, because we have our own funding, we're quite fast and quite large. So we have responded over the last years mostly on measles, where we treated more than 5,500 children, cholera, and massive malnutrition in all these locations that you see in front of you. So very big, and unfortunately still not far from enough of what's going on. So delivering aid in Somalia is extremely challenging. And I just wanted to show you a few main obstacles before I'll also show you a few opportunities. So one of the main challenges is, of course, this security. And there's a lot of armed groups, and this is something you don't want to get caught in, which has an impact on our access. So it's difficult to just get in a car and drive around. I was discussing with Martin just before, we have to take a plane, we land in the middle of a village, we can't go out, it's difficult to do outreach, it's difficult to drive around. So security itself is extremely difficult. And this is not only the armed group, it's also the violence within the communities that exist. So access in itself is actually also a challenge because we don't have access. We somehow question or have a lot of questions for our own quality of care. How can we guarantee good quality of care if we're not always present, if we can't do bedside training, if we can't make sure the protocols are followed up? What is really the impact there? Insufficient actors. So it's a country where the needs are so massive, where the national product or the national expenditure on social and healthcare is extremely low. More actors are needed. But again, with security and access, how does that mean? So huge needs are not only there, but are also left behind because of the insufficiency. And then indeed the complexity. It is one of the places where everything is complex. The setup, every location is different because it has different authorities, different people in power, different needs, different access, different clans. So extreme complex, and thereby again the lack of impact. So I think all of these will be the main challenges of what we see. But luckily there are also opportunities. And I'm glad and thankful, Martin, for inviting me today. I think it's also very nice that one of the things is that we together can highlight the impact of this crisis. So for me, it's extremely important that Somalia is not a forgotten discussion at the dinner table, on the political level, on medical societies, on every level thinkable. We hear often, yeah, but Somalia, it's been 20 years of measles, it's endemic, of yeah, there's every year cholera. If you compare measles, we had 5,500 cases in a year, where in some cases, 2 cases of measles would be enough to declare an outbreak, and a massive response will come. And we are desensitized by the situation in Somalia. So the opportunities today to share with you and share it further would be let Somalia.
Det här är nära Somalia.
Jaha.
Sorry, I thought that was a question. So indeed, let it be the core of discussion. Let it be going towards funding and additional operations in the country. And indeed, let's share our experiences and lessons. And that's where I wanted to leave you today for any questions or comments or further.
Thank you so much, Djoen, for sharing this presentation. Very interesting and for sure a very difficult situation you are describing. I think we open up with the opportunity for the audience to ask questions. Anyone who has a question, just shout out.
Julian Preda here. I wonder how many physicians, how many doctors are there right now working in Somalia from your organization?
So good question. Our organization, we support mostly our frontline workers. So our doctors, surgeons, nurses are from the MOH, the Ministry of Health, even though in some places don't exist the ministry that much, but it's mostly to avoid contracting, recruitment, different kind of challenges. So definitely not enough. But I think this is one of the biggest questions you have for Somalia, is that and I've been asking this for 2 years to main actors, what are the main gaps in healthcare? How many staff are available? How many doctors? And there's so many gaps. There's so many private funding. Everybody can start a private hospital in the morning, be operational in the evening. There's very little control. So our organization alone, we have 800 staff, of which only, let's say 30 would be physicians. And then the rest, most of it will still be guards and cleaners. So it's very little. And since our biggest programs are maternal health, mostly midwife, we run with 2 gynae ops. So it's very minimal actually.
Thank you. Any other questions?
Hi, thank you very much for a great presentation. I wonder, is hunger and starvation and causing these things, is that an element that is used to have power over people, a political element in this context, or do you have any comments on that?
That's a very good one. So when in 2017, and sorry, I'll take you back to the last major drought that hit the Horn, MSF or Doctors Without Borders, we were working in Ethiopia. And one thing that we realized is that even though there might be food distributions, not everybody has access to food. So even it might not be purposely used to divert, there is such a system in place where the vulnerable continue to have lack of access. where power brokers, gatekeepers, they're in control. So there is definitely this, in any humanitarian crisis where indeed things are diverted in a way. And this is our main concern. How can we make sure that specifically the minorities and vulnerable groups also have access to this food? And I think one of your questions, or the question is what is in our mind all the time, how far is being used by indeed all the different actors, the clans, the communities, and even the people that you that are doing the transport and different things. And I think the answer is that we literally don't know about what. Would be very surprised if nothing of any of that aid is indeed used for different things. And that makes this place so extremely complex, because the insecurity, because the follow-up, because the monitoring difficulties. I think that is a bit of risk that we're willing to take in a way, because we need to make sure that at least some will arrive of where we intended to go.
Thank you very much.
I'm also coming with a follow-up question on that, because if I compare with the food insecurity in, for example, Tigray, which is quite close on the border with on the Ethiopian and Eritrean border, it's often described there that the access to food is actually used as a weapon in the conflict. How much of that is the case in Somalia, and like if you compare the different factors for the lack of food, how much is like conflict contributing in comparison with the drought that is maybe more common as an explanation in the media?
That's my personal feeling. In that sense, we monitor slightly where people are coming from. So in our project, we ask where people come from, and our feeling is that somehow people are more or less free to move, even though it's difficult and travel for days. We do have the feeling that people are actually moving towards areas where there's easier access for distributions. So I'm not having the feeling that it's a massive weapon in that sense, more that there is a literal huge lack of availability. So even though there were cash distributions, some markets are really empty. So it's not that the food is somewhere and that we witness it and not arriving. So it is delivered in places where it's more or less accessible and let's say safer to deliver. And we see people coming from all over the country moving. So if you look at these displacement models, there's about stories of 1 million people displaced, and they move from states to different states, which is very abnormal, because a minority clan would not go to a different state where they know they are the minority. But if they know there is aid being delivered, they still are more or less free to move. So this has not been a narrative widely out there as what you mentioned on Ethiopia. I mean, it's not I'm not saying that it's impossible, but it's not the feeling that we have. The real feeling is there is no water and there is no food. And thereby really there is really the access to it more than that.
Okay, we see some hands in the air here. I think I don't know who was first. I give the word to Eric Turner.
Thank you very much. Yes, Eric Turner from SIDA HQ here in Stockholm. Thank you very much for the presentation. It was great. I have a couple questions. It's obviously a humanitarian crisis in Somalia. My question to you is, what is your assessment of the national healthcare, the capacity within the national healthcare system in the country? And the other one is, if you look more on the long-term sort of development side, not the humanitarian, where do you see us doing the most value? What are the best things to build on that exist out there? Thank you.
Thank you for the question. I think it links nicely to the question in the chat of, if I had one wish, reasonable limits, what would it be, or for the project? No, I mean it's clear that, and we as a humanitarian organization, we do realize we don't operate in a vacuum, right? And yes, we focus on life saving, but medical care in this context involves everything. It involves a political solution. It involves other actors for water and sanitation, shelter, safety. So in that sense, we really realize it's not a singularity. We don't work in this vacuum, and thereby we need political actors to do the job as well. However, if we look at the diagram about stabilization, and there is a massive military activity ongoing, which has a military objective, which is stabilization. And we shouldn't confuse the two. We shouldn't confuse stabilization with humanitarian, or humanitarian with indeed state building. The important thing now is this, that you need to have people alive to be able to actually start having sustainable solutions, start building development. But of course, the question is, at the end, the national expenditure on healthcare is less than 5%. Questions are like, yeah, if all this money goes to security, where do you save more lives? Right? Is it by healthcare or by protecting them? So I think at the end, of course, you want a very clear, stable healthcare system that is centralized, that is followed up, different referral pathways, no confusion with primary healthcare or private healthcare. So the complexity and the way where you want this country to go in terms of healthcare and access is clear. But at this moment, we're so with our faces into the acute emergency that we really feel like, okay, let's start by providing food, water, primary and basic healthcare, and then later on look at sustainable solutions. So it will be dangerous to only look at one angle of the coin. If you only look at sustainable solutions or only at humanitarian. So I'm glad there's other people trying to make the linkages, and I think that is the main wish. You know, at this point, we overcome the acute crisis now. We avoid further acute malnutrition and hunger, and then further build on that. But the conflict is all around. So one of the aspects is, of course, you know, stability.
Well, thank you for that answer. I see Johan has a hand in there.
Hi, thank you. Well, I wondered, how do you think that the Swedish health community or the Swedish community can advocate for Somalia's case? You spoke in the end about that this needs to be up for discussion, but could you be, well, how do you think we should talk about it, and what do you think we should advocate for?
Different levels, I would say. I'm already I'm very humbled to see so many people show up for this webinar, and I think as a human being on a personal level, interpersonal level, it's specifically the people in this room with our profession, your profession, make it discussable. But the Swedish government, SIDA, but also different governments are quite prominent in the donor group in Somalia. So within our connections, within the media, within our political engagement, there are these actors, as mentioned, of the vacuum that are extremely essential to what's going on in Somalia. So I think it is, besides being, you know, funding, working as a doctor, go for a mission, discuss it with the family, with friends. I heard there's a massive diaspora in Somalia. What are the initiatives ongoing there? And that is more an interpersonal level, but on a more political level, the Swedish government is quite prominent when it comes to the discussions in this country, and also extremely, so it's important that they are aware of the situation, and that it's a situation that is beyond this drought. It's beyond the discussion of the famine over the last few months, and therefore, like I said, we see hundreds of children each year. And it's horrible that the discussions come to this drought, but for us, it's been horrible for the last 15 years. So let's not make it only about this moment, and continue the discussion even be further than that, I would say.
Thank you.
Thank you very much.
Any other questions in the audience? No one right now. So I have actually a question on the F word, the famine. Like you mentioned, that it's, I think it's great that you highlight that this crisis is about more than the drought and the famine, but it has been discussed, as you said, a bit, if it is a famine, and should they declare a famine? I read an article in Guardian where this was brought up, and also they discussed if it was if the Somali government hesitated to declare a famine because they didn't want the whole UN system or body to come in and intervene and they affect their own autonomy and so on. What is your thoughts about that? Is there a famine? Should it be declared, or is it maybe a big question, but still?
Yeah, not a very big question. And I like to bring it down that for hopefully, the declaration for us in that sense shouldn't matter, and it should matter what we see on ground and the children that are admitted. Families, indeed, it's a very political thing, so it follows a very strict criteria. That in this case, there were 2 reviews over the last 6 months that are based on these IPC data, looking at food insecurity. And there's a very specific group that looks at these indicators and then decides if there's a famine or not. And if the criteria are met, then yes. If they are met, but the data are not so reliable, it's a likely famine. So it's a very political thing with, indeed, like you said, it's people from the UN and partly the government also there, right? So at the end, for us, we understand the discussion, but we also understand the notion how political it is, and we would like to refocus the fact on that we call it a malnutrition crisis. A famine or not, for us, we see massive numbers. If there is a famine, it will show that indeed we failed to address, to make it worse, but at the same time that we still need to have action. If it leads to funding, I mean, I wouldn't say, let's not do it, but this shouldn't be the main point of attention. It should really be what is the impact of the lives of these communities. Same for measles. I mean, yes, it's horrible that we keep saying it's endemic, but at the end, 5,000 families completely disrupted by a disease, that should be enough. So for us, we like to shy away from that discussion. But yeah, it is extremely political, and both sides will have good arguments of why or why not to declare. And we lucky have to stay, and we can stay out of that.
Mm-hmm. Thank you. Any other questions?
I have another question if anybody, if it's okay.
Shoot.
So talking about how much do you think that the war in Ukraine has affected the current situation and the food crisis part of the situation in Somalia?
Yeah, to be very honest, I wondered that myself as well, right? So it's action, reaction, the correlation is always a bit tricky. We do know that a huge part of Somalia's maize for cattle and wheat comes from that area. So I would be surprised if the war there did not affect indeed the price level. So that's one. But the other thing, it's also the attention. It's also the media, the focus on what's going on. It's very safe to. It's close to home, and we have a lot of attention on there. So even internally, we see an impact. Where you could struggle getting enough staff, or you could struggle getting the supplies in time because they are somewhere else. So even though it makes, it could make sense in some ways, there is an impact nonetheless. It's not that straightforward that it's just the prices or something else. I think the whole combination of is definitely something that we witness. And but I know that there are different studies ongoing looking at exactly these impacts. And I'm as curious as you are to hear a bit more on what exactly comes out of that.
Thank you for raising the complexity. Of course, it's extremely complex since there are so many levels that it affects things.
And COVID also had so one of the biggest exports was cattle to the Gulf states, which was all on its behind during COVID. And then after that crisis, so we also one thing I actually failed to mention is that all these layers of crisis, so the existing access to healthcare, conflict, COVID on top, low immunization levels, the war in Ukraine, food prices, other attention things, everything has an impact on the resilience of these communities. So in a way, at one point, they don't bounce back anymore. because every little coping mechanisms that they had is gone, and the only coping mechanisms left are the most radical ones you can imagine, like indeed this, letting one child die to save the others. So it's really all these layers of emergencies that depleted these communities of all their resilience. And yeah, I think that is the main. And you don't bounce back as easily from 3 droughts in 12 years and this kind of situation.
Is it possible for you to elaborate a little bit more on how the COVID pandemic affected the crisis and the health status in Somalia?
Yeah, the angle, the disease itself, the case management, I was a bit surprised on how few people we received. We started also COVID wards and oxygen, but the impact on that sense, we felt maybe people didn't have access, or maybe didn't come to us, or maybe there was not enough tests, so you don't know the positivity, and maybe people are already, there's such a high mortality rate on other levels that you don't know what causes what. But I was a bit surprised on how little we saw. It had a huge impact on travel because of all the different tests coming from different countries, moving around, airlines. So it was very difficult to go to the projects. But I think one of the biggest impacts was both the vaccination level, which was already low, but if the immunization was just almost on hold. The standardized EPI in primary healthcare was pretty much was pretty much stopped. So we are expecting an immunization level of 20 to 25%, and thereby the impacts now are massive when it comes to that. Importation was on hold, so there's not enough vaccines. Socially, economical, I think, it was already that bad before. I'm not expecting that much, but mostly these healthcare situations are for sure. And a lot of people left. So where diaspora is sending money, there's also a lot of diaspora coming back to Somalia and taking prominent roles within their community. And I wouldn't be surprised many also again left during such a situation.
Interesting. Anyone who has some question? We have 5 minutes left. Bjorn.
Sorry if there's some sound in the background. My name is Djoen, working for SIDA with Somalia. Just a short question about immunization. Now in 2023, are there ongoing campaigns to get the immunization level up? And do you think they will be successful? Thank you.
Thank you. Now, good one. We've been, as Doctors Without Borders, we've been pushing quite a bit for about 1.5 years to boost, let's say, the immunization. And so 2 things, of course, the standard EPI, the standard immunization, and trying to boost it. And there's different initiatives ongoing. There is a nationwide catch-up campaign with WHO, the World Health Organization, together with the ministries, trying to do an integrated polio, vitamin A, deworming, measles kind of campaign. And at the same time, we've been pushing for short-term outbreak vaccination. So when there's a hotspot around a big city or in a big city, to do a big campaign within days or weeks to really address that situation. So yes, there's many things ongoing. However, the complexity of vaccination in this country is something where we have questions in terms of impact and quality of the campaign. Access is very difficult. So often you use an implementing partner and then no idea how much the coverage would be. Normally, you would do a coverage survey after a vaccination campaign, which is extremely difficult to do because you can't go. Then there's questions on the quality of the vaccines and the chain, the cold chain, how is it administered and brought as well? Because, for example, there were, in one of the areas, we saw, I think, about 5 or 6 campaigns in the last year, and the cases are not going down. So then at one point, you start questioning the quality of the campaign itself, which has multiple factors, right? It's from A to Z, could be different causes, but we do have questions on how it's going. Then there's still pockets of inaccessible for anyone, where both government or international organizations won't go or can't go, so that the immunization level will still be low. And then there's still areas where they don't want any vaccines, because it's against also a bit of tradition. So I think all these complexities, I'm happy that things are happening. And we are a big advocate to increase. We also were a big advocate to increase the age group to at least up to 15 years, which we were lucky with the Ministry of Health that measles will be included up to 10. So we're somewhere in the middle. But something still, yeah, it needs a big push. And I think that's where I'm happy that you joined the call. I think actors as SIDA, but indeed, this is where we need to be extremely critical on these kind of things. When indeed a proposal comes to up to 5 years, we need to come with the argument, well, let's look at the last 2 years and why not increase the age group? So I think that's extremely important to keep highlighting that. So I'm optimistic, but also careful in the impact of that.
Thank you.
Thank you, Djoen.
If you need more detail, feel free to reach out also on those specific details. We're happy to elaborate.
Great.
Yeah, no, I might do that actually. So I might reach out later. Thank you very much.
We have about 2 minutes left, and maybe I'm going to ask you, Djoen, if do you have any, after this 45-minute talk, any last message that you would like to sum up with?
Yeah, I think well, based on the questions, indeed the complexity is quite clear. And but what we like to do for our public communications for Somalia is simply to highlight the impact what it has on families, and to indeed go beyond all the political questions and take a moment to realize indeed how heavy it can be on different families and different things. And I think that's where also our motivation, our drive comes from as medical professionals. So I think this is I would like to end with that between all the political things, just let's see indeed that specific family in Baidoa with sometimes 24 children with nothing left.
Thank you. I think we sum up there. It's time to get back to work for most of us. But we thank you a lot, Djoen, for taking your time and sharing this. And as I said before, we can share this on our YouTube channel for people who couldn't attend and want to see it afterwards.